Hey, good morning, folks. Dr. Jeff McCowich here, paediatric oncologist at the Children's Hospital at Westmead in Sydney, Australia. And today I want to take you through an abstract from the American Society of Clinical Oncology's meeting. So what I'll do is I will share my screen and get rid of me. And now you should be seeing my browser. And there it is. And okay. And I'll show you what we're going to do. We're going to type in ASCO.org. The American Society of Clinical Oncology has its big annual meeting in June every year in Chicago. Okay. Now here's their main web page. And what we want to do now is go to meetings and education and go down here to abstracts and presentations. And what we'll type in here, if to search all of the abstracts, is if we type in ASCO annual meeting, and I want to show you an article today that's on neuroblastoma. So we hit return, and here's 224 results. Well, we don't want that. We want to go just to the things presented this year at the annual meeting. So we go up there, we pick 2025. And now there's different session types. There's going to be oral abstracts, publication only, and poster. We're going to go to the oral abstracts, and this will narrow it down. And so now here's the two neuroblastoma papers that were presented at the ASCO annual meeting in June 2025. Now, today I just want to look at this first one that's about immunotherapy, but you'll notice the second one here on here is a very important paper. We'll have to have a good look at that in time because eflornithine or DFMO is now available in Australia. So we better know the data anyway. But today I want to talk about this one. Now, I just want to point out, by the way, that I haven't signed in. So I'm just showing you what ASCO puts out there in the public domain and that's available to everyone. So I hope that doesn't upset them. In fact, if I had paid a registration and went to the conference, which I usually do, when you look at this screen, you see here's slides. We'd be able to get the slides, but you have to have logged in and have registered to the meeting to get the slides. And guess what? I didn't. You can even watch the talk that the first author gave, Dr. Ladenstein. But no, you can't get at that either unless you've bought a registration and attended the meeting. By the way, you can, even though the meeting's finished, you can still purchase that and get it, and maybe I should, but I don't want to violate anyone's copyright too much or at all. So today we're just going to go through the abstract based on what is provided free by the ASCO group and is available there, and add to it anything that I just happen to know as background knowledge, not of this paper. So yes, there's the first author is Ruth Ladenstein, and she's the first author on any number of very important neuroblastoma papers, particularly from the CIOPEN European group of neuroblastoma. She is also the leader of a number of the big Ewing sarcoma papers that have come out of Europe as well. So very productive, and from St. Anna Children's Hospital in Vienna, in Austria. And here's the rest of the authors, and this is a European trial, and I don't know all of them, but I know some of them. And Dominique Coinet is in Paris. I know that. Juliet Gray in the UK. Cormac, I know, he's Irish. Holger Lode is the senior author, a very prominent figure in the group. The other thing to point out is that this was at that meeting, and it's an oral abstract at the pediatric oncology session. The meeting is 99% adult stuff, breast cancer, lung cancer, prostate, colon, but there's plenty of pediatrics to keep you busy. Normally in room S504, year after year, there's enough pediatrics to fill out an agenda for one who attends the meeting, which is to be recommended, I must say. Now, like I said, there's posters and there's oral abstracts at the meeting. And By and large, the highest impact things tend to be in the oral abstract session. That's where the biggest, sort of highest impact presentations are made. But some people just don't like speaking in public, or some can present the data better on a poster. So the posters are very important and they're a good place for networking. But it's in the oral abstracts you tend to get the most high profile things. Anyway, let me plough through this paper that Dr. Ladenstein presented. And if you want to pay for a registration, then you'll be able to get the slides and hear the actual talk. But I'll tell you what I know. Okay. Now we're talking about neuroblastoma, and we're talking particularly about the immunotherapy that goes with neuroblastoma. And I wonder if I can make the screen bigger here. I think I can, so you can see it better. Let's see how that works. Yes, we can. All right. So we're talking about dinutuximab beta, which is an antibody treatment against a chemical called GD2. And GD2 is on the surface of neuroblastoma cells. It's also on the surface of normal cells, unfortunately, and that's why some side effects arise. But it's an antibody that's against GD2. And importantly, you should know that there's two products, really. There's the American product that was tested in the Children's Oncology Group trials, and it goes by the name Unituxin, and it's presently made, I think, still by United Therapeutics. And the Americans used that antibody and they used their way of giving it. And the original paper gave it with interleukin 2 and then with GM-CSF. And that was the first one that really came out and proved that this improved the outcomes in high-risk neuroblastoma. Now, the Europeans, meanwhile, developed a product called dinutuximab beta, and it's been commercialized now as a product called Qarziba with a Q. And that's the one that the Australian government has provided funding for, is for Qarziba. So for various reasons, we are often using Qarziba, but not always. So if we're in a trial with an American group, we may be using their product. But today we're talking about Qarziba or dinutuximab beta, which is the commercialized form in Australia and the one that's supplied by the Australian government, particularly for use in high-risk neuroblastoma after transplant, provided disease control is adequate. Okay, now, so the European group have studied this for years and years and years. And they showed that if you gave it as a longer intravenous infusion, like for 10 days or something, there were less side effects from it compared to a shorter infusion. All right. So less side effects. But in this paper, that they're addressing the question, but what works better for event-free survival and relapse rates, long-term infusion versus short-term infusion. So they'd already showed it was less toxic, but which one works better against the cancer? That's what's going on here. And these are results from their SciPen trial, HRNBL1. All right. So this was a study for patients who had high-risk neuroblastoma. Okay, and they were either the ones that had metastatic disease. It would have been above a certain age, I expect. It might have been 18 months or 12 months. The definition of the age cutoff changed in recent decades. Anyway, it won't have included infants with metastatic disease, likely. So metastatic disease or a localized neuroblastoma that had the NMYC gene amplification, which makes for high-risk disease even in a localized tumor. So that's what they called a high-risk patient for the purpose of this study. Metastatic disease over the age of 12 or 18 months, whatever it was, and or localized disease but with NMYC amplification. Okay, so they got the high intensity induction and surgery and a high dose treatment. So the high intensity induction, that's the initial phase of chemotherapy with heavy dose, intensive dosing of chemotherapy, and you would need to check the presentation, but for a long time, the European group have used a regimen of chemotherapy that got abbreviated as COGEC, COJEC, notable for the presence of carboplatin, which isn't such a feature in American induction regimens. So it has one of those C stands for carboplatin, or maybe the J does actually, now that I think about it. J, for some reason, often is used to abbreviate carboplatin, such as in the retinoblastoma protocol. JO, the J stands for carboplatin. And there's probably a good reason for this, but I can't remember what it is. Anyway, the European induction has usually been with this COGEC combination that has all the other drugs in there, etoposide and cyclophosphamide and cisplatin and various other drugs in there. So that's what they would give as an induction, and provided the tumor responded well, adequately, then the patient would proceed to surgery. Usually that means they have to have had control of metastatic disease that was adequate and the tumor has shrunk to the point where it's operable to allow surgery. And so then the patient would undergo surgery to remove the primary tumor. And then they may or may not get another round of chemotherapy after surgery. We would have to check this talk and see. And then there would be this high dose therapy that you can see here with busulfan and melphalan. So that means they've harvested peripheral blood stem cells earlier on in induction and put them in the freezer in liquid nitrogen. And then at this phase, they give high dose treatment with busulfan and melphalan and give back those autologous stem cells. So it's an autologous bone marrow transplant, uh, normally in hospital, 4, 6, 8 weeks, depending. And the notable thing here is that Americans historically didn't give busulfan and melphalan. Americans have used a regimen of carboplatin, etoposide, and melphalan, and carboplatin thiatepa, and have even shown that two transplants in some settings is more effective than one. So this is more a European approach to give one high-dose procedure, but to use busulfan and melphalan. Okay. And to give radiotherapy, local radiotherapy, meaning to that area where the primary tumor was and where it got resected from. So typically, for instance, maybe the flank, maybe the tumor was in the adrenal, and so the radiotherapy is given to the area where the tumor was and where it got operated on. Now, maybe there's some to metastatic sites. We'd have to check the detail. All right. So that's what they've all had before they come to the randomization in this trial. So the patients who achieved at least a partial response prior to the transplant within equal or less than 9 months between diagnosis and transplant, they were randomized in the study. So they had to have at least achieved a partial response prior to the transplant phase. And a partial response will be defined by agreed international neuroblastoma response criteria that will involve that there wasn't disease progression, that there's an improvement in the metastatic sites, usually on an MIBG scan. It may require that the bone marrow is resolved completely. These are all documented somewhere and possibly in this talk. But, there are strict criteria in this protocol that would have defined what do we call a partial response prior to the transplant. So they had to have a partial response, then have their transplant and their radiotherapy, and they had to have got to that transplant within 9 months of diagnosis. All right, so they're our patients, high risk, partial response or better, and they've had everything: induction, surgery, transplant, radiation. All right. Now, here's the randomization. They're all going to get 5 cycles of immunotherapy. And it's either going to be the STI, the short-term infusion. Okay, so that's 20 milligrams per meter squared per day, an 8-hour infusion every day for 5 days in a row. That's the STI, the short-term infusion. Where is it? Short-term infusion, yes. All right, so it's an 8-hour infusion daily for 5 days. Or just come down here now, the long-term infusion gave half as much per day, but stretched it over 24 hours, not 8 hours, and gave it for 10 days. So it's a one big, long 10-day infusion, 24 hours a day infusion. And they probably started in hospital at first, and then typically, if everything's going well, maybe the patient went home with a infusion pump or something like that. We'd have to check the detail on that. But it may have started in hospital to make sure they're okay. Now, by the way, at the same time, they were doing a second randomization. That's this one that's mentioned here, to either be given subcutaneous interleukin 2 for 5 days with the short-term infusion, or da, 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 interleukin 2 here, it stays 1 to 5, day 8, 10, 12, 14, 16. All right, so that's a separate randomization now. That's so interleukin 2 revs up the immune system. The idea is to see whether revving up the immune system augments the efficacy of the antibody. But that's not the topic of this paper. And I think they've reported the results of that randomization. You'll have to go and find it. But I'm pretty sure they've reported that and worked out whether interleukin 2 improves on things or not, or whether it adds to toxicity or not. I think that's all out there for you to find as your homework. Now, in addition, everyone was given this medicine, oral isotretinoin, or 13-cis-retinoic acid. This is the same product as Roaccutane that teenagers take for acne, skin acne, but it happens to have a differentiating effect on neuroblastoma cells. So it doesn't kill them, it drives them towards a more benign counterpart like a ganglioneuroma. And the Americans likewise include this in their immunotherapy phase to give this. So here you see it's days 19 to 32. So it looks like it's going to be about a 35-day cycle each time with the immunotherapy in there. And then after that's finished, they get the retinoic acid and then they start another cycle, something like that, which will be outlined in the talk if you get a registration. All right. So there we have it. This paper is about the 5 days with 8 hours a day for 5 days, or the 10 days, 24 hours a day for 10 days. STI, LTI. All right. And here are the results now. This is what they did. So study went from 2009 to 2018. Think about that, right? What's that? 9 years, multiple countries, right? All of these countries are in it. Here's all Spain, Israel, Austria, Germany, Italy, Germany, um, France, multiple countries. This is a big job to get all those countries together for 9 years, all those regulators, all those everyone. This is a huge job, but that's what you have to do with rare cancers. And they enrolled 705 patients from 18 countries, randomized and eligible for this analysis. And the median follow-up time is now 7.7 years. So that's a long follow-up for a disease like neuroblastoma. Most of the relapses that are going to occur will occur in that time. Almost all of them would. Some might occur later, but not many. So that's good follow-up. Key patient characteristics. There we go. Age 1.5 to 5 years, 65%. So I'm pretty sure that will mean that the stage 4 patients under 1.5 were not included, but I'm not sure. But that means that 35% of patients were outside those age groups. So they might be younger patients with MYC amplification or in a localized tumor, or older patients with stage 4 disease or MYC amplification. Anyway, most patients are in that age bracket, which is what you'd expect. Now, the disease status before the high dose procedure, remember I said you had to have a partial response or better. Well, 56% had a CR, a complete response. That means you can't see the tumor anywhere. The MIBG scan shows no metastatic sites. The bone marrow aspirate shows no infiltration with malignant cells. And there's no mass of tumor that's identifiable on the scans at the primary site or elsewhere after the surgery, etc. So before transplant, 56% had a complete response. And that's a good number to put in your head, right? That's saying that with the European induction regimen in high-risk neuroblastoma, 56% of patients achieved a complete response. 38% had a non-complete response. So what does that add up to? 50, 94%. So I don't know where the other six are. But remember, this is only patients who get to this point. Patients who have the induction and don't achieve an adequate response, or even if the tumor grows during induction, they're not included in this study. So there are a group of patients who don't benefit from treatment and don't do well, and they do not get to this randomization. And their disease is a bad one, and they've needed to find some other treatment, so they're not in here. Actually, what I said is wrong here. This doesn't mean 56% of patients achieve a CR at all. That's not right. There's some, no, delete that from your brains. Anyway, in the ones that got randomized, 56% came into it in a state of a complete response. 38% had a non-complete response before their transplant. And by the time they got to this study, they might have had a further improvement. They might have been in a complete response because the transplant and the radiotherapy got them a further response. So anyway, that was their disease status before the transplant. Okay. NMIC amplification, 43% of patients had NMIC amplification. I think the old figure I used to have in my head was that about 25% of neuroblastomas had NMIC amplification. I'd have to check that now. Uh, but that but that includes low risk patients, 25%. So here it was 43% of the patients who had high risk disease and got to the got to this study, right? So anyway, more than one metastatic compartment, 78%. Okay, so that probably means they had bony disease and bone marrow disease, maybe, or I'd have to check the fine print, or they had lymph node disease, distant lymph node disease, as well as bone marrow disease, that sort of thing, or liver plus bone, or something like that. The time between diagnosis to the antibody, not to the transplant, was more than 9 months in 48% of patients. So I guess that means 52% got to the antibody phase within 9 months from diagnosis. Okay. All right. So there were no significant difference in patient characteristics between the short term, the 5-day, and the 10-day cohorts, except for one, that the time to antibody treatment being more than 9 months was 59% in the long term versus 37% in the short term patients. Now we'd have to hear from them why that was. Presumably that was just it just happened, unplanned. I can't see a reason why it would fall that way. So the long-term group, 59% of them started antibody after 9 months, 37% in the short-term group. Don't know what to make of that. All right, now we get to the main results, and we're talking here about the 5-year event-free survival. Now, they haven't said it, but hopefully that's measured from the time of randomization. You would think it would be. I would expect it would be, not from diagnosis. So we're talking about 5-year event-free survival. So they've survived 5 years, still alive, and they haven't had progression of their uh, of their cancer. So they haven't had a relapse of the neuroblastoma, or any spot that was there hasn't got worse. That's what we're talking about, 5-year event-free survival. And they might have other definitions of what they call an event, like the development of a second malignancy or something. I can't tell you. I should know that, but I don't. Okay, but the 5-year event-free survival was 0.65, so 65% for the long-term infusion versus 0.56 or 56% for the short-term infusion. And the p-value for that comparison is 0.041. So that's statistically significant. So that's the key message of this paper. The long-term infusion, which we already know to be less toxic, the 10-day, 24-hour day infusion, 65% 5-year event-free survival versus 56% for the short-term infusion. So firstly, that's a meaningful difference. That's 9%. Secondly, it's statistically significant. So sometimes you see a 1% difference and it's statistically significant because there's, thousands of patients in a breast cancer paper. It's not really meaningfully different. It's even though it's statistically different. This is statistically significant and it's a meaningful amount. 9% difference. That's huge. Okay, next, the incidence of relapse. All right. 33% for long term and 42% for short term. So there we are, that's a 9% difference again. 33% chance of relapse versus 42%. And that's statistically significant. P-value 0.034. Okay. And so, by the way, these are useful numbers to have in your mind if a patient is about to commence immunotherapy after induction and transplant and radiotherapy and everything. But as a group, 65% of those patients in European hands were alive and disease-free 5 years later. And about a third of the patients, given the long-term infusion, this is, had a relapse in this paper. And that's useful in counselling families on if they really want to know expectations, and that's a figure you could attach. All right, so then they've done some obscure statistical thing that's beyond me, a pseudo value regression analysis. We'll take their word for it, but a significantly worse outcome for stage 4 patients with more than one MC, more than one metastatic compartment. Okay. So if you've got more than one metastatic compartment, the outcomes were worse, significantly worse. CHR equals 1.97. I think that'll probably mean corrected hazard ratio or something like that, 1.97, which sort of means the chances of an event are 1.97 times the patients who don't have more than one metastatic compartment. All right. Now, also, if you were in a CR, presumably pre-transplant, because that's what they talked above. It might mean CR prior to immunotherapy, but probably not. It probably means if you're not in a CR, a complete response prior to transplant or prior to immunotherapy, you would have to check their fine print. They also had a worse outcome. Their p-value is borderline there, and a hazard ratio, and significantly worse for the short-term infusion, which we already know. The 5-year event-free survival is what they reported up here, superior with the long-term infusion. So they're the results. Long-term infusion has a superior outcome. 10 days given 24 hours a day is superior to 5 days given 8 hours a day, even though the total antibody dose given in that time is similar. And we already know it's less toxic because they told us that in the background. So here we are. Yes, we previously reported that long-term infusion increased the safety profile, less pain and inflammation. There you go, Lancet 2018, and an abstract from 2019. And here they demonstrate that long-term infusion is also associated with an improved outcome. And that's pretty important to know. So what do we need to know that we don't know here? Well, we don't know the results of this randomization, this second randomization up here, about whether giving interleukin-2 improves the outcome in either arm or both arms or overall. We don't have those results. I think they've published them, but I just haven't got them here, and it's not for me to um, chime in. Um, we don't know that. We presume they've done an analysis of NMIC versus amplified versus not NMIC amplified, and they haven't mentioned it here as an independent risk factor in this multivariable pseudo-value regression analysis. So anyway, we'd have to check that out and see, well, what do they know? There'd be other things like time to transplant, time to immunotherapy, all of that. I'm sure they've analysed them, and the fact that they haven't highlighted them here suggests maybe it wasn't significant. That's what it suggests. But you need to look at the whole publication and hear the whole talk to know, and I don't have that. I'm just sharing what they've already shared in the public domain to the whole world. What else can we add in here? There's other things that have emerged since then as risk factors in neuroblastoma, the presence or absence of an ALK mutation, segmental chromosomal anomalies, loss of heterozygosities and chromosome losses, chromosome gains, things like that that might have emerged. I expect there'll be all sorts of other analyses that maybe were never planned but might now be planned, or maybe they were planned but they haven't been done yet, or haven't been reported, or the data isn't complete. There's other things to know. Um, how many? Also, I guess it would be useful to know the time to relapse and the shape of the survival curves and the EFS curves that they'll have in their talk will give us a clue to that. When do relapses occur in this disease? Do they occur in the first year after immunotherapy? Do they occur during immunotherapy? Do they occur 2 years later? These are key things. And with follow-up of 7.7 years, they'll have something useful to tell us there. Um, what else can I tell you? Sooner or later, someone's going to want to know whether the European product, Quasiba, is any different to the American product, Unituxin. I don't know if a full-on head-to-head comparison will ever be performed. There'll be questions about whether these results apply in people who've had a different transplant. You can never separate the results completely from what treatment went beforehand. So it might matter what treatment went beforehand. American patients might have had two transplants. So might that affect whether this difference persists? I don't know. Certainly, a less toxic regimen, even if it was only just as good as the short-term infusion, that might be a benefit. But they're actually saying that they've got better results, so that's pretty good. It'll be also interesting to hear how they actually manage these patients in Europe. Do they put them in hospital now for the first few days and then send them home with a home infusion pump? Did they keep them in hospital for the whole time? What did they do during the trial? And what do they do now that they've all got more used to doing it? But that's what we have from their abstract. I think this is a very important finding that the long-term infusion is less toxic. We already know that. And the event-free survival and the incidence of relapse were superior, were better results if the long-term infusion was used. Pretty important stuff. So see if you can register for the meeting if you can, or somehow find out the rest of the data. But I can't share it with you here. But the one thing we'll want to do next is to see if where is it? If I can get to telling you next about this DFMO paper that's also been reported, and I'll see how I go. Anyway, that's it for today. Thanks, everybody, and we will stop there. Bye.